So, hey everyone, this is the presentation on biceps tear repair. Spencer and Zach got this ready for us, so we appreciate it. They're going to walk us through the presentation, and then we'll post this video and share it with you all so you can read things and reference it as you wish in the future. So you guys can take it away.
Yeah, so like Mike just talked about, we're going to be talking about specifically a distal biceps tendon rupture because that's just a little more just common and physiologically possible. This little overview of just what we're going through, just everything from the epidemiology to basic anatomy, how it would present in a clinic, and then just how you would fix it. So just a little bit of background on this type of injury. It can happen to people of all ages, but it's very common in the dominant arm of middle-aged men. This is just when they're like exerting themselves. Specifically, like I wanted to give this presentation because my dad had this injury in December. So he went through this entire process and got surgery and is currently recovering from it. So I got to see kind of firsthand how this works. But specifically the bicep rupture, the tendon rupture is involved in only a small portion of the bicep muscle tears that we hear about a little more frequently. There's a lot of risk factors included with this type of injury. That's anything that I list on the screen that varies between steroid usage, smoking, just having hypoperfusion in that area, and then just impingement mechanically from other structures in the area, as well as some tendonitis and stuff like that as well. And then with the injury, it can rarely present with median nerve compression. I guess that's just due to a buildup of scar tissue and then just the structures in the bicipital aponeurosis just pressing on one another. So like I mentioned, we're going to go through just a couple of the basic anatomy elements. Spencer and I are just M1, so it's not like we know everything, but we did take HA1 somewhat recently. So the distal biceps tendon rupture is going to occur near the insertion on the radial tuberosity that's on the radius, and this occurs commonly with the eccentric motion. So it's kind of like when your arm's fully stretched out, like if you're doing like a preacher curl, and then just the force of the weight is greater than the force that your biceps producing and causing that tear. And the MRI is something really important to distinguish whether it's a complete tear or partial tear and whether muscle's incorporated. There's other small like sports medicine type of tests that you can do as well to figure out if there's a tear, but the MRI is more conclusive. So with the anatomy as well, so there's the biceps short head and then there's the biceps long head. And then as you can see in this screenshot I took from Complete Anatomy, their origins are slightly different, but the insertions are basically the same. Technically, they're in different portions of the radial tuberosity. One's more distal than the other. So it is possible to have bifurcated tendons, so you wouldn't insert on these two distal and proximal areas of the radial tuberosity, respectively. But it's most common that the tendons are a singular tendon, and then the whole thing just inserts on the radial tuberosity without much distinction. And then I listed some other structures here just to be mindful of. So this insertion point is superficial to the elbow joint capsule itself, the annular ligaments, which are on the medial and lateral sides, respectively, and collateral ligaments as well. It is deep to the bicipital aponeurosis. So if you want to think of that as just a sheath covering this area, that is something it's made of fibrous tissue. And if you have this sort of biceps tear injury, commonly, I'll reference the hook test in a few slides, but you can have an abnormal hook test result just because the bicipital aponeurosis is kind of messed up and getting in the way and presenting like a tendon identified. So with this presentation, I mentioned that it's with the eccentric biceps motion. You'll hear a painful pop. I know Spencer and I were just talking about this about an hour ago, but I guess he had a friend in high school who tore both of his bicep tendons at the same time. So that was that was probably pretty painful. And as you guys might know or remember from HA, the strongest supinator is the biceps. So this is mainly going to present with a loss of supination. Flexion is something that's done most by the brachialis. The biceps is a accessory muscle in that. So you'll also get some issues with flexion, but not as much as with supination. And then the hook test here, since I'm sharing my screen, I guess I can't really tell if this is, if you guys can see what I'm demonstrating. But this is one way that they'll diagnose a biceps tear tendon in the clinic. So they'll do it in this FABS position. So the shoulder is going to be abducted, the elbows flexed to 90 degrees, and then they'll have the patient supinate. So this can be done actively or passively. And then it's really easy to isolate that biceps tendon. So if it's intact, you should be able to insert your finger beneath the tendon. It's very easy to do on yourself, but if you don't have a tendon there, then obviously you wouldn't be able to feel anything, which would indicate a positive result for the hook test, aka a complete biceps ligament tear or tendon tear. Then there's also something called the Ruland bicep squeeze test. So this is something where the patient's gonna have their arm flexed, just on the side, and then slightly pronated. And the physician's just gonna stabilize that elbow joint and the wrist joint as well, I believe. And then the patient's just gonna attempt to supinate. And whether they supinate or not is an indication of whether this tendon's intact. So these are pictures from my dad with his injury. I guess he sent me this a few days after his injury, but he lifts pretty frequently, so he's got pretty big muscles that he likes to talk about. But it made this picture pretty easy to see. So they call this the reverse Popeye sign. So the muscle kind of just retract upwards and bunch up just because there's no tendon pulling it downward anymore or more distally. So in this view, you just cannot see a tendon here. I guess I should have had him send a picture of his left arm as a control, but I think it's pretty easy to identify that there's a missing tendon. And then there's also some bruising here. It's a little tough to see in this picture, but that's also common in the presentation. So this is not his MRI. This is just one I found on a website, but so this is an MRI taken from the vantage point of that FABS view that I talked about with the hook test earlier. So this will allow you to see the entire length of that biceps tendon. This is a sagittal image over here with just displaying a singular tendon here, and then the bifurcated version over here. So this black portion here is splitting here. And I don't have the most technical terms for MRI language, but that's what that would look like. And then here are some of the abnormal ones that we'd be looking at. So this is just a coronal cross section of the distal humerus. And here you can see just a bunching up of the tendon. So since it's thicker than normal here in this view because the tendon's not actively being stretched anymore. And then this is something a little more difficult to interpret here. But so this one on the left, it's actually also bifurcated distal biceps tendon, but it's only partially ruptured here. And this is something that you can't really see just based on this picture. You need to see this one on the right as well to indicate the coiling of the tendon, like you would over here in this cross section. But with the partial rupture, you're just going to see a thinner overall tendon. And then I guess when you're scrolling and looking at the different views, you'd see some coiling in another image. But at one point there would be a view in which the entire tendon is intact because it's only partially ruptured, which I couldn't find any images on the site I was looking at of a complete rupture, but I guess from my simple understanding, it would just, this would bunch up a little higher. So another slide about just some non-operative treatment. This is not the preferred route. There's a lot of indications for surgery when you present with this sort of injury. But it seemed like the main thing was if patients are older, typically sedentary, and then would have issues with anesthesia or just quality of life with getting a surgery, that might not be something that's indicated for them. So if they're a younger individual, like perhaps middle-aged or younger than that, they're pretty much always going to get surgery, just because this is something that you want to have full range of motion of your elbow joint, obviously. So that's something to be taken care of. Right after the surgery, I know that that's something that you're giving a sling and brace, and that's something Spencer will talk about later, but that's something you can also be provided non-operatively, again, just to control that range of motion. So physical therapy is something that is required with non-operative and operative treatment as well. And then, like I mentioned earlier, the strongest supinator is the biceps muscle. So your greatest strength deficit will be with supination if this isn't something that's operatively corrected. And especially common with just the complete tear for obvious reasons. So some people can be non-responsive to this sort of non-operative form of treatment. It's involved with a lot of scarring. It can be involved with more of that median nerve compression I talked about earlier, just due to that scar tissue and then all the other structures in that area. And then timeline matters as well. So later on, I know Spencer will reference this as well. Sorry if I'm giving too much away, Spencer, but there's a video that you guys can watch of an example of the surgery. The video is only or the portion that's this operation, specifically the single incision procedure Spencer's going to talk about. It's only about 20 minutes or so. It's not too bad. But the surgeon in that video specifically remembers, or I remember him saying that the 10 days is what he likes to see. Within 10 days of the injury is when he likes to operate. Because after that, you get some buildup of scar tissue, and it's definitely possible to operate. And many people will present to the clinic, months, if not years after having this sort of injury. But there's a lot of scar tissue that they have to get out of the way and stuff like that. So it makes it a little more difficult. But typically within 10 days, as soon as possible, this is something that needs to be looked at in order to preserve not only muscle function, but neurovascular function in the area as well.
Great. Okay. Yeah, just kind of jumping off where Zach was at, this timeline really is crucial. I know a lot of things with this, when the patient's presenting with this, it needs to be a goal of care discussion right away. Again, they always say the timelines we've seen are anywhere between 2 weeks, 3 weeks. One of the surgeons that we watched in this video said he likes 10 days max. Again, they can do operations way out from then, but you start to lose your landmarks from all the scarring and fibrous tissue. You lose your sheath for your biceps tendon. It becomes more complex. You have some death that's starting to occur with that tendon. And now you're starting to talk about potential grafts that may need to be used. So the earlier, the better, ultimately. So the methods of repair. There's really two major ones that we could find in the literature. So it's one that seems to be used more often today, but there still seems to be little preference. It seems to be more surgeon preference, one or the other. The first one is just an anterior single incision, sometimes called a limited Henry approach. And then the other one's going to be a dual incision Boyd-Anderson approach. So for the first one, it's going to be a single 4-centimeter longitudinal, sometimes L-shaped incision in the antecubital fossa. So right here, longitudinally in the antecubital fossa, again, 4 centimeters, going right here between the brachioradialis here, the pronator teres here. You can see the bicipital tendon diving here laterally, and you see the bicipital aponeurosis coming here immediately. The L-shaped incision is sometimes used. It really depends. They'll take a small incision that's going to go medially here, and then what that will happen when they'll do that is typically with a major contracture of the biceps, where they can't get up underneath in this longitudinal incision and fish out the tendon because it's so high up proximally. So sometimes they'll use a little bit more exposure here going medially to get up, digitally kind of dissect and retrieve the biceps tendon. So for this anterior approach, there's a couple of fixation techniques. The first one's going to be your suture anchors, your intraosseous screw fixation. Your primary one that you're going to see now is a suspensory cortical button. It's also the strongest one. So a lot of the papers that I had looked at typically always with this, except for some of the older cases, we're using some suture anchors. Again, another point was a hybrid technique is stronger than any of the isolated techniques. So a lot of them that you'll see will be a mix between the suspensory cortical button with an additional interosseous screw, which I'll get into these more in a second as well. For your dual incision, it's going to be a bit smaller of an incision. It's going to be transverse on the antecubital fossa here. But you're also going to have a second longitudinal incision that's going to be on the posterior lateral elbow. And it's going to be over the palpated clamp. I'll get to that on the next couple of slides. But the primary fixation technique for this is going to be a bone tunnel. And something worth mentioning before we go any further is that really for any time you're drilling into the bone for any surgery, you're going to make sure that you are doing copious amounts of irrigation, making sure all those bone fragments and debris aren't getting down in wherever you're setting your tendon. It's going to cause more inflammation, prolonged wound healing. So never want that. Maybe if I can move forward. There we go. So surgical positioning. So for both of these procedures, you're going to have the patient supine. You're going to have the arm abducted at 90 degrees, kind of resting at an arm table here. You're also going to kind of goes without saying with the supine position, but you're going to have your hand supinated like this, facing towards the ceiling. Another note is that sometimes a tourniquet or a proximal cuff is used here just in case, the radial recurrence there in the antecubital fossa. It's a lot of vasculature, a lot of veins. So they'll make sure they set this here in case they get into any of those veins and need to maintain some hemostasis while they ligate or cauterize. Okay, so this is kind of the anterior approach for both techniques. So these are some of this is the common pathway for both. So after the antecubital incision, you're going to do some blunt dissection within the deep fascia. You're going to make sure, one key thing is you're going to make sure that you're protecting the lateral cutaneous antebrachial nerve. So this is going to be a branch coming off your musculocutaneous nerve. It's going to be serving some sensory into your lateral arm. So something you want to make sure you're preserving that because that is one of the most common complications. It's emerging between the biceps brachioradialis right here in this area where you're going to be working. So you want to make sure that you're protecting this. It's also why when you're doing retraction within that cavity, you want to make sure that you're not too aggressively retracting on the lateral side. You don't want to be causing any extra damage to that and causing any sort of sensory loss on the lateral forearm. Next is going to be some digital dissection, like I was mentioning earlier. So taking the finger up or sometimes using a Kelly clamp or a hemostat if it's very deep up there, maybe even a tonsil, up pretty superficially to grasp the biceps tendon stump. Then it's going to be tagged and then retracted out of the incision. So if you look here, this picture is a little bit confusing. So this is going to be distal over here. This is proximal. You can see the incision they made here. You can see the tendon. There's already a couple of whip stitches in here already, but you can see the tendon here, and here's the end of the tendon stump right here. So they have managed to get up there and retract the tendon out. They now have it out of the incision. So another key point is if this tendon stump coming out of the incision is about 6 centimeters or greater in length of usable tendon. What I mean by usable tendon is the end of the tendon tends to become very bulbous from the inflammation and the tear. So a lot of it has to be debrided when you're doing this. If you have less than about 6 centimeters of usable length, oftentimes that's when you're going to be talking about using some kind of allograft to make sure that you have the proper amount of length to allow full extension of the arm. And see, yeah, this, when you have to use a graft, they'll typically not use this on the distal portion. They'll typically start proximally, leave it in, and then use the extra length to get to the radial tuberosity. So blunt dissection is then completed down to the radial tuberosity. And this is when you run into these radial recurrent vessels, and they're ligated and divided, as we talked about. And another nerve coming in here is the posterior interosseous nerve, which dives into the supinator. So again, within this field that you're working in, another reason why this lateral retraction is really avoided. And these two damage to these two nerves are some of the most common injuries you see. I know at least with the lateral cutaneous, it's been reported upwards of like 15% of cases for some institutions. So in the video that Zach had mentioned, I know the surgeon was very, very apt on very gentle lateral retraction and a lot more medial retraction just to avoid any sort of damage to these nerves, especially with the posterior interosseous. So you're talking about losing a lot of, now you're talking about motor function for extension of the hand. So we're talking about pretty major complications. Again, the tendiopathic thickening or the bulbous part of the end of the tendon is debrided. And then the like a heavy non-absorbable, like a fiber wire suture is placed throughout the tendon, starting at where the tendon meets into the muscular belly of the biceps. And this is done using a looping, locking loop Krakow technique. And you should end up at the end of it. You can kind of see this technique here, how it's looped through here. You should end up with your 4 ends of your sutures here. And then your tendon diameter here is measured, and that's just for when you're going to be prepping the bone. I know I've also seen that some people will take a non-absorbable suture like a Vicryl, and they'll just basically take this end and approximate it to this end to make it more of a less ribbon-like and more circular to better seat within a completely circular bone preparation that they'll be making. And then now specifically to the dual incision. So this one's done with a bone tunnel fixation. So for this one, you're now going to be putting the elbow into 90 degrees of flexion. So starting completely supine, and now we're moving up into 90 degrees of flexion. So a Kelly clamp is then passed along the medial border of the proximal radius and to the posterior lateral side. So you can kind of see where we were coming from our anterior transverse incision here, crossing here. And this is what I was talking about with tenting the skin here to find where you're going to be making your posterior lateral incision. So you're going to be piercing through the aconius muscle through here, making your incision. So then the extensor and supinator muscles are split, exposing the radial tuberosity. You're going to make sure that you spend time to debride all those tendon remnants that are still attached there on the radial tuberosity. And you're going to pull your tendon through this tunnel created to the posterior lateral side. So then an acorn reamer is used to create a cavity. It's about 5 millimeters deep. Obviously, it's going to depend on the size of your patient, size of bone that you're working with. But then the dimensions are matched to that of the distal tendon when we're talking about size. So this typically I've seen about 10 by 8 millimeters. You can see this here. It's basically just drilled in here. This one's a bit more elliptical than these dimensions. But you can see here that the tendon was pulled through the tunnel that was made. The bone was prepared here with the acorn reamer. And then we're going to have 2 to 3 holes. I've seen almost only 3 holes, but 2 to 3 holes are created on the anterior side. And they're going to be all leading into this trough that was created. So then the suture ends, what I've seen was 2 of these ends are going to be going into the middle hole, 1 to each side, and then tied off here. So you're going to pull these through here, and you're going to be pulling a lot of tension to seat the tendon down into this trough, and then they're going to be tying off just right here along the bone. So and then closure, obviously. But then for the anterior single incision, for this one, we can start with the suspensory cortical button. So a small diameter burr hole is made through the radial tuberosity. This is kind of picking up where we left off with exposure, the radial tuberosity, and locating it, but this time we're coming in through the anterior approach. So this burr hole is going to actually go through the entirety of the radius from the anterior to posterior cortex of the bone. So then after you have this small burr hole, I've seen 3 to 4 millimeters, quite small. Then an upsized acorn reamer is going to be used, and it's going to be going through a few millimeters deep into the bone, and this is where the tendon's going to sit. So leaving the posterior cortex on this side, you're going to have a very small, about 3 millimeter sized hole going through. And about halfway up here, you'll see it get much larger, and that'll be the cavity that the distal end of the biceps tendon actually is seated in. So this is when you will get your cortical button, which it kind of looks like, let me do this. Very simple. Excuse my drawing, but your cortical button will kind of look just like a little piece of metal about like this, and you'll just have 2 holes on either side here. So you'll take your 4 ends and you'll pass them in and through, going in opposite directions here. And this will allow basically, this will allow for better tension, is what I had read. And what they'll use is some sort of, I don't know the exact name, but they'll use some sort of deployment device that will allow you to pass the cortical button through, going from the anterior to posterior surface. You'll be going through the hole, through the smaller 3 millimeter hole to the opposite side. And when it's deployed, it'll now sit like, so it'll be going through, passing like this, and then once it's deployed, it'll kind of use tension to kind of suspend it on the back of the bone a little bit like this. And something that's really crucial to this is I've seen some, like, I saw one older paper that said that what they'll do is once it's deployed, they'll pull up tension on the sutures to see if they can bring the arm off the entirety of the arm off the table. But what I've seen more recently is almost every time you're going to be using, you're going to be getting an X-ray, making sure that that button is fully seated on the posterior side of the bone before tensing the tendon into it. So after that, you'll apply tension onto the sutures, which will slowly pull the tendon down into the cavity and seat it in there. So there'll be, I've seen read a couple of ways. Some people will leave that there with just the cortical button, as there's a lot of interference with the bone, with the tendon sucked into the cavity. Some will tie off directly over the entrance of the tendon into the cavity made, and some will actually suture back up along the proximal end of the tendon here and tie off away from the cavity. And where I saw the interosseous screw used pretty much exclusively was once this tendon is set in said cavity, this is a good picture of it right here. So once the tendon is set and tensioned in there, a screw is put in here to make sure that that tendon isn't coming anywhere. I guess you can kind of see here as well. There's the cortical button that I was talking about. You can see that it's laying flat here, providing tension. And then this is kind of in an X-ray, what they'll be checking for to make sure that it's set properly and it's not going to come back through the drilled hole. There's also, this one was a bit harder to look into. I haven't seen as many of these. So again, on the anterior position, this looked kind of like a bone tunnel situation, whereas a trough was created for the tendon, but from the anterior approach. And they'll use these suture anchors and basically be seating it into the trough, much like the bone tunnel, but again, from an anterior incision approach. So after the surgery, everything's closed. This is some of the timelines. There's a lot of variability that happens after the first month, but the first week, almost exclusively going to have immobilization at 90 to 110 degrees of flexion. And you're going to have it at 0 degrees of pronation or supination. And then in that 1 to 4 week timeline, you're going to be using a hinged elbow brace, which I believe Zach talked about a little bit. And then at this period, you'll be doing some gentle passive flexion and active extension to about 30 degrees. At about 6 weeks, depending on the progress of the patient and the range of motion, you're going to be taking off the hinged elbow brace, and you're going to be doing some flexion and extension allowed against gravity, still no weight-bearing activities yet. Then about 2 months, you're going to start some gradual weight bearing with elbow flexed, but there's still going to be that focus on that range of motion then. Then at your 4 to 6 month interval, you're going to start, for people within active people in sports, younger patients in sports, you're going to see a restricted return to sports. For your adult patients not involved, you're going to see a continuing increase in weight-bearing activities. But when we get to about our 6-month point, that's when we're having more unrestricted return, as long as the range of motion looks approximating normal and the strength is starting to approximate what it was before. So the biggest question is, which technique is best? I know I mentioned it pretty early on, being some surgeon preference, but there's some pros and cons to both. So with the dual incision technique, you're gonna have a lot more dissection. Obviously, aesthetics, you're gonna have 2 incisions, more dissection, more inflammation from all the tissue debridement, all the tissue, incision, manipulating all that tissue from both viewpoints. There's also going to be a risk of something called where'd it go? Radio-ulnar stenosis. And what that is basically just with all the manipulation of the periosteum and all that manipulation, creating that tunnel through the interosseous membrane, with all that wound healing there, you can have some calcification occurring there. And it's quite rare, but you can basically have some bone growth that will connect the radius and the ulna there from all that manipulation. And that's going to cause significant impairment of your supination, pronation ability. Again, very, very rare, but it is a consideration for this technique. One benefit of it is it has demonstrated, not statistically significant in the studies I'd looked at, but it did show some reduction in the risk of nerve injury. Some have attributed it to better visualization from both entry points, but again, really not statistically significant, but a consideration for the nerves we were talking about earlier. So the lateral antebrachial cutaneous nerve, the posterior interosseous nerve, and even the radial nerve, which the posterior interosseous is coming off of. For the anterior single incision technique, there has been some reports that it demonstrates some greater postoperative flexion and supination. Again, not statistically significant in anything that I've seen, but again, another consideration. So the big point for it is that both techniques are still utilized and they demonstrate statistically similar functional scores, regardless of technique. So a lot of times it boils down to patient size, other considerations for the surgeon with their training, which technique they believe is better. And this is the video that we've been talking about a little bit. I think it's great. I know Zach took a look at it as well. Really great. It's a live commentary as the surgeon goes through and kind of does the entire approach. He used the cortical button with the anterior single incision approach, and he kind of walks through all his considerations, little details, even more so than what we've talked about. And it's really great. Check it out on OrthoBullets if you have time. And I believe that is it.
Did you guys come across anything that was like, as you're placing that tendon back in the tunnel? I know we talked about it for like the ACL thing a little bit a couple months ago, but was there anything as far as like tensioning of that tendon, or like how much or how little you should actually, how much or how little tension you should actually put on it when you set it?
I might have to, for me, what I saw, especially in some of the papers I had seen, I didn't see any sort of device be like, at least they didn't talk about it. And a lot of these papers that I've seen were more about outcomes, which we were looking at with like complications and such. A lot of like the little minute details were kind of derived from like OrthoBullets using like actual technique stuff. I didn't see anything about tension. I did see the load bearing that you can be expecting with the different approaches, and that's where the cortical button became one of the stronger, especially for the anterior approach. I didn't see anything with the amount of tension that should be placed when setting it. Even in the operative videos we had watched, I didn't see any tensioner used or gauge for when they're tensioning it, more so just making sure it's set well down into the tunnel and then tying it off. I don't know, Zach, have you seen anything for that?
No, I don't think I can explain that anymore either. I
Sure.
don't think I know much about that.
Yeah, and I guess it's fair that if you don't need a graft, then you have like the original, roughly the original length, maybe as long as you set it closely to the bone in its original position, then maybe they just assume it doesn't matter.
You know, that's a good point too. I don't think I saw anything with that might be a consideration more with when you're using a graft. I didn't really see any actual techniques for when they're using the graft, if there's any additional considerations like that. So maybe that's
Sure.
something we can look into.
Yeah.